We're going to get started in a few minutes. Just we're waiting for more people to join us today. Welcome. So I think, Chelsea, we're going to get started if that works.
Okay. Okay, good afternoon, everyone, and welcome to today's webinar. My name is Chelsea Townsend, and I am the director of the South Carolina Prescription Monitoring Program, and I co-chair the NASCSA Education Committee. I'll be hosting this afternoon's webinar along with NASCSA's Kathy Keogh. Hopefully you guys read through the scrolling material while waiting for the webinar to start, which provides information regarding our sponsors, a NASCSA disclaimer, housekeeping items, and announcements. One thing to note is that travel scholarships for the conference are now available. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. So thank you to our sponsors. And thank you for taking the time out of your day to join us for today's webinar on tianeptine and other gas station substances of concerns. I know this topic is of interest to a lot of us in the group. Some states have already scheduled this at a state level, and others are possibly considering scheduling some of these substances at a state level. We are thrilled to have an extremely qualified expert, Dr. Michael White. So please allow me to introduce him. Dr. White is a distinguished professor and chair at UConn School of Pharmacy in Storrs, Connecticut. His research interests are in areas of comparative effectiveness and preventing adverse events from drugs, devices, dietary supplements, and illicit substances. His work has been widely published in multiple well-known medical journals, including JAMA and The Lancet, with widespread media coverage by mainstream media outlets. 5 of his publications were among the top 5 read articles in their respective journals in the years that they were published. And then his work has primarily been funded by the Agency for Healthcare Research and Quality with additional grants from the Donahue Foundation. I'm glad we are all here to join Dr. White as he shares his extensive knowledge on these substances that may be less familiar to some of us. So welcome, Dr. White. The floor is yours.
Great, thank you very much. Let me share my screen. And we'll get started. So first, thank you for all you do to try to keep the American public safe. I really appreciate everything that you guys are doing every day. So let's talk about the objectives for the first part of this presentation. Hopefully you'll be able to identify the pharmacology of tianeptine and suggested clinical uses, describe the abuse potential and the risk potential when used as a substance of abuse, and then define the current legal status of tianeptine in the United States. So tianeptine is an atypical tricyclic antidepressant, but one of the things that I want you to appreciate is that it doesn't work exactly like other tricyclic antidepressants. So, tricyclic antidepressants increase concentrations in the synapse of serotonin, but tianeptine doesn't boost serotonin concentrations in the synapse. It also has anticholinergic adverse effects, much less than what you would be seeing with tricyclic antidepressants. Tianeptine is not as effective as SSRIs and SNRIs for depression. So one of the pharmaceutical companies that was trying to look at tianeptine to be an antidepressant ended up ending that after their phase 2 clinical trial showed disappointing results. So tianeptine use has been discontinued as an antidepressant, but it still has some studies that are ongoing in the United States for things like migraine headaches and then for neuropathic pain. It's been studied for irritable bowel syndrome versus amitriptyline and has similar benefits, but like we were saying up above in terms of its pharmacologic profile, had less dry mouth and constipation. Here's one of the interesting things is that as you boost the dose, tianeptine is a novel mu agonist for opioid receptors. So it's an agonist at mu opioid receptors, but in standard doses, it doesn't induce respiratory depression. So in one study, they studied it as potentially an antidote for alfentanil and remifentanil-induced respiratory depression. And you can see here, they limited the dose to what they thought was going to be the prescription dose of 50 milligrams, and that it had non-significantly reduced the respiratory depression from alfentanil. And here you can see the specifics in terms of the overall ventilation capacity in liters per minute. But as the dose got above what was going to be the standard dosing for a prescription type product, they found that actually the opposite ended up happening. Intravenous tianeptine, where the doses achieved blood concentrations of 500 to 2,000 nanograms per mil, worsened remifentanil-induced respiratory depression. And here you can see the reduction that occurred. So tianeptine doesn't help very much, and in high doses or concentrations does worsen people's ability to breathe. And here I wanted to talk about, the 50 milligram dose that they were thinking about for a prescription use for the product versus the recreational dose that can be up to 3,000 milligrams. So since it is stimulating opioid receptors, one of the questions is, can you reverse it with a standard public health drug like naloxone? The answer is yes. Naloxone has been reported to successfully reverse opioid-related tianeptine effects. So if it's not a traditional tricyclic antidepressant in terms of its ability to boost serotonin levels, what could it be doing in the area of depression, that could be of beneficial effects to some patients? They think it's related to a ketamine-like glutamate modulation, and that has been shown in some of the preclinical studies. Now, we know that ketamine has benefits in acute depression reduction. Tianeptine is being studied outside the United States for this purpose. No clinical trial results are as yet available. Now, glutamate modulation means differing effects in different areas of the brain. It's not really well understood how close ketamine and tianeptine are in terms of some of the benefits and some of the risks that they may have. So if we look at clinical trial dosing of tianeptine, which again is around that 50 milligram dose, the incidence of dry mouth, constipation, dizziness, drowsiness, and postural hypotension are greater with amitriptyline than what they had seen with tianeptine. But it doesn't mean that there's no anticholinergic type side effects. It just means that it's not as pronounced as it is with amitriptyline. Insomnia and nightmares, though, did occur more frequently with tianeptine than with amitriptyline. And remember that, nightmares, disorientation, and things like that can be related to abuse of things like ketamine. Tianeptine's pharmacokinetics, you can see it has very, very high bioavailability, very high protein binding. Its metabolism is not through the cytochrome P450 enzyme system. So if you're taking cytochrome P450 enzyme inducers or inhibitors, it's unlikely to be able to change the concentration over and above what you would get with your standard dosing. When someone takes tianeptine, they're likely to hit their maximum effect of the product in about 1 hour with oral administration. The elimination half-life is about 2.5 to 3 hours in most people, but in the elderly and people with renal dysfunction, you can see that it is prolonged up to about 4 to 9 hours. Now, one of the reasons that this is important is because the drug will remain in the body for about 5 half-lives, right? So you could have some of the effects of tianeptine that would be occurring, out to something like 10 to 15 hours. So what about the legal status of tianeptine? Well, tianeptine is approved as an antidepressant in France. It's not DEA scheduled in the United States, but it's not FDA approved for any reason. And it's been specifically stated not to be a dietary supplement. And this is because tianeptine has been hidden in some dietary supplement products through adulteration. You can see that sales have been banned the last time that I had checked a few weeks back in Alabama, in Florida, Georgia, Indiana, Kentucky, Michigan, Mississippi, Ohio, and Tennessee. It's sold over the internet. It's sold at gas stations. It's sold at convenience stores and smoke shops. In a lot of these places, it was being sold as a dietary supplement. Some vendors stated that tianeptine could improve brain function, that it could be used to treat opioid addiction, and that it could reduce anxiety. But there's no information in the literature that supports these marketing messages that some of those people were providing. Higher doses is associated with a mu opioid receptor-like euphoria. So just like other opioids, if you hit a certain dose threshold, you could end up getting some of those same euphoric-like effects. Tianeptine has been associated with 5 deaths that they know of so far in the United States. So now let's look at tianeptine specifically as a substance of abuse. The adverse effects have included agitation and drowsiness, confusion, sweating, rapid heartbeat, high blood pressure, nausea, vomiting, slowed or stopped breathing, coma, and death. So some of these are things that you would see with other opioids, right? The problem with breathing, causing nausea, coma, death, drowsiness, and confusion. Some of the other ones like rapid heartbeat and increases in blood pressure rather than decreases in blood pressure is something that is distinguishing of tianeptine versus other opioids. People that try to take tianeptine and try to dissolve it and then inject it can run into some additional issues. And one of the issues is that there are some silica particles that are associated with the dosing form. And if they're not fully filtered out, could end up causing inflammation, right? So you could end up with phlebitis, or you could end up with skin irritation, depending on the source of injection. Tianeptine doses are not always displayed on the products that people are purchasing. And if they are, they're not necessarily always truthful. Now, some of that may be to try to hide it in things like dietary supplements. In other cases, they may be trying to tell you that they have more or than they usually do, or it may be that they have less than what they're putting on the package. So because they don't have to adhere to good manufacturing practices, there could also be variability in the same products at different times when those products are being sold. So just because a consumer may have used a product and then they go back and they use the same name brand product in the future, doesn't mean that they're getting exactly the same thing that they were getting before. Tianeptine can be adulterated with other drugs, including barbiturates. In poison control centers from the year 2000 to 2017, you can see that there's been an aggregate of around 218 calls related to tianeptine exposure. But you can see before 2013, only 11 of those calls were related to tianeptine. And then we can see that it increased in 2015, it increased again in 2016, and then it increased to 81 in 2017. Now, among the exposures for which the level of care was reported, you can see that 44% of people ended up needing treatment. They were evaluated and they were released from the emergency department. And 25 of those cases, or 24%, the patients were admitted to a critical care unit, right? So the severity of some of the adverse effects for approximately a quarter of the people who were taking it was severe. What kind of effects were they seeing? Well, you could see that tachycardia was very commonly an issue. 25% of people, hypertension around 11%, and then the occurrence of arrhythmias in around 4% of people. If we switch from cardiovascular events to neurological and pulmonary events, you can see agitation occurring in about 22% of people, drowsiness in about 17%, confusion in about 13%, respiratory depression in around 5.3%, and then around 4% of people having coma. Nausea, like we were talking about before, also has occurred in some of these poison control center reports. And then the occurrence of cellulitis in around 1.8% of people. What kind of treatments were given to some of those subjects? You can see that fluids were given in about 35% of people, benzodiazepines in about 27%, oxygen in around 11%, naloxone in about 10%, and then the need for antibiotics in around 10% of people also. So again, when you're injecting some of these products, it's hard to be able to maintain sterility. And when you have inflammation, you have cellulitis, you have other issues such as that, there's a risk of secondary infection. So from 2000 to 2017, the Poison Control Centers reported 29 withdrawal-associated calls. So here are people that were reporting withdrawal. Tianeptine was the only substance reported to be associated with withdrawal in 74% of those calls. And what were the symptoms that people were receiving? We have that listed here: agitation, nausea, vomiting, tachycardia, hypertension, diarrhea, tremor, and sweatiness. So a lot of these are very similar to what you would see with other opioid type withdrawals, right? So constipation is commonly seen with opioid use, diarrhea with opioid withdrawal. So what about individual case reports or reports that have been reported in the media? Psychosis, respiratory depression, stupor, coma, suicide, dependence, nightmares, insomnia, and then withdrawal symptoms. Some of these case reports were based on single substance ingestions, but others were based on multi-drug ingestions. And since the data had no control group, there can be issues with helping to determine the absolute causality for each adverse event with any individual drug. So whenever you have a multi-drug ingestion, it's really hard to tease out whether one is an innocent bystander, a cause, or whether the two together were a cofactor in causing those issues. So let's go through a conclusion for tianeptine specifically before we move on to some other drugs. Agitation, aggression, and nightmares. Benzodiazepines would be a therapy that you could use to try to treat those adverse effects. Check the patient's serum sodium, though, because the package insert suggests that hyponatremia can occur. And remember that the drug in Molly or ecstasy, MDMA, can also cause hyponatremia. So fluid replenishment could be important in those people, but the fluid replenishment should most likely also include a replenishment of patient's sodium. The next one is psychosis. If you're having a psychotic episode, benzodiazepines or an antipsychotic can be used. If your patient is experiencing coma and sedation, watchful waiting, checking the patient's oxygenation and hemodynamics is a good first step. However, if it has coma and sedation that's impacting oxygenation or impacting hemodynamics, then you're going to need therapy specifically to maintain blood oxygen levels and to maintain patient hemodynamics. So that could include, giving people intubation. It could include drugs to be able to maintain normal hemodynamics. If your patient is experiencing respiratory depression, naloxone would be a first-line therapy, possible intubation, and then in people who are receiving naloxone, people who are intubated, supplemental levels of oxygen. Hypertension and tachycardia, if you're experiencing those, beta blockers and non-dihydropyridine and calcium channel blockers could provide benefit across both of those things. And since in a lot of cases they're seen together, going with a beta blocker or non-dihydropyridine calcium channel blocker can give you the 2-for-1. Now, if the patient has hypertension, but the hypertension or tachycardia is being caused specifically by the patient being agitated, a benzodiazepine could either be a good alternative therapy or an adjunct therapy to the beta blockers or non-dihydropyridine calcium channel blockers. And then, of course, for nausea, the use of an antiemetic drug. So what is the conclusion? Tianeptine is a novel pharmacologic agent, but it's not FDA approved for any reason. It's a synthetic product, so it never should have been put into dietary supplements. The treatment of depression, nerve pain, opioid use disorder, or other medical disorders with an addictive drug shouldn't be done without medical supervision. So even if data comes out in the future to show that there are benefits, it would be a very dangerous thing for someone to try to do at home alone. Tianeptine adverse effects can be serious and could include coma and can include death. Tianeptine can be contaminated. It can be adulterated. There's no quality control standards with the sale of these products in the United States. So you run the risk of heavy metal contamination, of bacteria, mold contamination. They could put other substances of abuse in those products, or they could actually put dietary supplements in those products that could also reduce patients' cognitive ability, or could also suppress bleeding or breathing, and that could cause additional adverse effects for your patients. Tianeptine is an addictive substance and can lead patients to require it or require other opioid drugs for their daily function. So while some people may be using tianeptine in times where they can't get their hands on other opioids that they may enjoy or may like better, there are other people who may be using tianeptine as a recreational drug now, but could end up becoming addicted. And then if they don't have the capacity to be able to get tianeptine, could move over to other opioid-like drugs. So now let's talk about some drugs that have been around for a while, but are also being sold in places like gas stations and convenience stores and over the internet. So here are the objectives for some of these talks: identify what a synthetic cannabinoid is and some of its common street names, the prevalence of use in Europe and the United States, including in children, delineating the main pharmacologic effects of synthetic cannabinoids that drives the desired and adverse effects, describe the major adverse events that are associated with synthetic cannabinoids, how the incidence compares to cannabis products, and some treatment recommendations. And then finally, describe some of the major withdrawal phenomenons from the synthetic cannabinoids. So in a worldwide survey of about 15,000 participants, 17% of people had reported ever using a synthetic cannabinoid. That's a pretty huge number. Synthetic cannabinoids are also commonly abused in children. According to the National Institute of Drug Abuse survey of 12th graders, 5.3% of them had identified using synthetic cannabinoids. What is the current legal status? The 2012 Synthetic Drug Abuse Prevention Act made 15 synthetic cannabinoids Schedule I products. So they're illegal to buy or sell or to possess. Dozens of synthetic cannabinoids are now specifically illegal. But one of the potential issues is that the United Nations Office on Drug and Crime found that in 2013 alone, there was 150 new synthetic cannabinoids that were created. So one of the things that they do in their products is they'll rotate between active ingredients. So they're all synthetic cannabinoids, even if they are structurally very, very different. And that does two things. One of the things it does is it makes its illegality a little more occluded, right? Not as clear cut. And the second thing that it does is it makes it really hard for a commercial company to come out with a screening drug test for synthetic cannabinoids if the synthetic cannabinoid that's in the product is constantly being rotated over a very large number of potential synthetic cannabinoid products. So they passed the Federal Analog Act, and that was supposed to make it illegal to sell, purchase, or possess chemicals which were substantially similar in their chemical makeup to Schedule I or Schedule II drugs. But to this point, it's been exceedingly hard for prosecutors to convince non-science-minded jurors that a chemical is substantially similar, or that the person that was selling it or the person that was purchasing it knew that it was substantially similar. Why are a lot of kids using synthetic cannabinoids? And why are other people like athletes, prisoners, military personnel, miners, and train engineers using synthetic cannabinoids? It's because they're trying to circumvent drug use prosecution and avoid being penalized for driving under the influence. So where regular cannabis products would show up with routine drug screens, the synthetic cannabinoids do not. There's an inability to access cannabis in some people, making them want to use synthetic cannabinoids. And then in some cases, you could end up with a lower cost product, and some people will try it for that reason. So just like THC, the active ingredient in cannabis, there's a CB1 stimulation causing the classical tetrad of effects: hypothermia, analgesia, cataplexia, and locomotor suppression. THC, though, is a partial CB1 agonist, while the synthetic cannabinoids are full agonists. So the effect is more pronounced when you are using a synthetic cannabinoid than when you were using THC. The affinity is much higher for synthetic cannabinoids for the CB1 receptor than what you would see for THC as well. When they used one of these synthetic cannabinoids, what they found was that the rats that were using them had an increased propensity to want to self-administer morphine. And it changed the mu receptor density inside some of those rats. So could the use of synthetic cannabinoids actually be something that could lead people into other types of risky behaviors with that substance or other substances of abuse? So according to the US National Poison Data System, the most common adverse events from Poison Control Center calls were agitation, tachycardia, drowsiness or lethargy, vomiting, and confusion. 11% of those cases had adverse events that were life-threatening or resulted in residual disability or disfigurement. 48% of cases required some form of medical treatment, 37% had only minor effects, and 4% had no adverse effects. Smoking synthetic cannabinoids or oral ingestion of synthetic cannabinoids are the most common way of administration. According to the Global Drug Survey, over 19,000 people, predominating from the United Kingdom, the US, and Australia, reported the use of cannabis, and then 2,176 people reported using synthetic cannabinoids. So they did a comparison of those two for relative risks for one type of product versus the other. You can see the risk for synthetic cannabinoids causing emergency department visits 30 times higher than with cannabis alone. Okay. The percent of people who were hospitalized who had not recovered within 2 weeks of that hospitalization was non-significantly higher. If people use cannabis and they use synthetic cannabinoids together versus using cannabis alone, you can see the risk was 19.6 times higher. So synthetic cannabinoid users were more likely to report panic and anxiety, paranoia, agitation, chest pain, visual hallucinations, seizures, and accidents than the users of cannabis did. So we know that paranoia is a very common adverse effect that's associated with the use of cannabis. And about 35% of cannabis users did end up having that adverse effect. But look at the synthetic cannabinoids. 62% of people, right? A really high percentage of people within that survey. So synthetic cannabinoid adverse events, the CDC identified 16 cases of acute kidney injury over a 9-month period that typically presented with nausea, vomiting, flank pain, and then serum creatinine elevations, with some people actually experiencing protein in their urine or red blood cells in their urine. Renal biopsies ended up showing acute tubular injury and acute interstitial nephritis. They think that rhabdomyolysis, or severe muscle breakdown, may be a mechanism for the acute kidney injury. So here, there's a substantial breakdown of skeletal muscle that ends up liberating the iron from the myoglobin that's inside the muscle, and then the iron ends up coming in and poisoning the kidney. According to the CDC, 14% of synthetic cannabinoid ED visits involved generalized tonic-clonic seizures. And a review of pediatric poison control center reports found that 15% involved those same types of seizures. So what about for motorists that are using cannabis or using synthetic cannabinoids? Well, one of the bad things about people using synthetic cannabinoids versus using cannabis type products is that the synthetic cannabinoids may be worse for people's ability to drive. Those arrested for driving under the influence of synthetic cannabinoids were more likely to be confused, disoriented, have incoherent or slurred speech, and had the inability to be able to hold their eyes steady, right? Horizontal gaze nystagmus, than those people who were using cannabis products. Those receiving synthetic cannabinoids also had a trend towards a greater incidence of motor vehicle crashes. And look at the disparity there between cannabis and synthetic cannabinoids. So contamination. There's no way to identify or recall bad batches of products. Products can be contaminated with pesticides, with herbicides, stray chemicals, and heavy metals. There have been some very large outbreaks. In 2015, there was a large outbreak in Mississippi where there was 721 adverse events that all happened over a really compressed time period. On the green in New Haven, Connecticut, near Yale University, in August of 2018, there were 70 serious drug overdoses over a 24-hour period. So for those of us in Connecticut, we'll all remember that day. On July 19, 2018, the Food and Drug Administration warned consumers that a batch of synthetic marijuana had been laced with rat poison. And it appeared in the Northwest, and they knew that it was laced with rat poison, and they put out consumer alerts, but they were still being sold, and they moved into other regions, including the Northeast, even after hundreds of severe bleeding events had occurred. In 10 states and the District of Columbia, hundreds of people ended up being hospitalized with severe bleeding, and 4 people died. So what about the treatment for synthetic cannabinoid adverse events? You can see for things like anxiety, paranoia, agitation, and psychosis, the benzodiazepines are a good place to start. Antipsychotics is an alternative for more severe manifestations of neurological adverse effects. For acute kidney injury, intravenous fluid administration, and then dialysis. So remember that intravenous fluid administration could decrease the concentrations of things like iron being liberated from the myoglobin, which could end up damaging the kidney. For tachycardia, negative chronotropic drugs, which would be your beta blockers and non-dihydropyridine calcium channel blockers, and your benzodiazepines, if that tachycardia was due to things like psychosis and agitation. Myocardial infarction, you would use all the standard treatments for myocardial infarctions. You could also use benzodiazepines. For seizures, benzodiazepines, or other anti-epileptic medications if benzodiazepines are ineffective. So like with regular cannabinoids, synthetic cannabinoids can also cause a hyperemesis type situation, and the treatment is the same as you would do for regular cannabis products: hot showers, antiemetics, and then electrolyte and fluid replacement. Withdrawal can also happen, and the withdrawal seems more significant than it is for the average person trying to withdraw from regular cannabis-related products. So the most commonly reported withdrawal symptoms, including agitation, irritability, anxiety, and mood swings. The mean duration of hospitalization was 8 days with withdrawal symptoms, peaking on day 2 and remaining elevated but stable over days 3 to 5. So while cannabis use disorder is a big issue for a large number of people, a relatively small percentage, right? But a large number in terms of absolute number, the risk for synthetic cannabinoids seems greater. And now for the conclusions for this section before we move on to talk about bath salts. While advertised as weed that you can't get busted for, it's a riskier product than regulated cannabis products in a number of different ways. Remember that the synthetic cannabinoids are spray painted on vegetal material, and then they soak up into that material and then get dried. They can have chemical like acetone and butane from the synthetic creation that can be dangerous, especially if you end up lighting it on fire because you're smoking that product. The constituents and the doses can change from product to product, and many have never been studied in humans. By this, I mean that you buy some of these products and maybe it has one of the active synthetic cannabinoids in it. And then you go back and you buy the product, but that manufacturer has rotated the active ingredient without your knowledge. The other thing is that some of the constituents we know some things about because they've been around for a longer period of time. But there's other constituents that can appear that have been newly synthesized, for which they know virtually nothing about its overall effects. It can be adulterated or it can be contaminated, enhancing the risk. And you could end up with things like hyperemesis syndrome, agitation, psychosis, paranoia, seizures, heart attacks, kidney or lung damage. So now let's talk a little about bath salts and flocka, right? Or under that catch-all criteria of synthetic cathinones. So here are the objectives for this part, very similar to what we had just talked about with the synthetic cannabinoids. So cat is a natural cathinone, and it acts as a sympathetic nervous system stimulant. Synthetic cathinones, though, are synthetic derivations on the cat structure that are designed to accentuate the degree of sympathetic nervous system stimulation. And because of that, it also increases its risk of use. So like the synthetic cannabinoids, the synthetic cathinones are riskier than the natural substance. Sold as bath salts, not for human consumption, trying to get around a loophole to allow it to be sold, to prevent detection from regulatory agencies. And actually, if you go on the internet now and you look at Tianeptine, there are still some places online that are selling it, but they're selling it for laboratory purposes only and not for human consumption. Again, trying to find a loophole in order to be able to sell it to vulnerable citizens. The bath salts that people were buying that had synthetic cathinones in them are not actually going to soothe you while you're in the bath. Rather, the products are snorted, used orally, or they're dissolved and then injected. They provide stimulant effects like cocaine and amphetamines. So their adverse effects, as you're going to see, are very much like what you would get from cocaine and amphetamines. There are numerous synthetic cathinone analogs. Some are explicitly a Schedule I product, while others may be illegal under the Federal Analog Act. So what about some of the pharmacology? All synthetic cathinones increase extracellular monoamine concentrations of norepinephrine, serotonin, and dopamine in the brain. Ring substituted cathinones mostly try to reverse the normal direction of transporter flux. So these are called releasers. Other synthetic cathinones work by being uptake blockers, which is how we usually think about products that could increase concentrations of norepinephrine and serotonin in the brain. So here are several of the common ones, but just remember that there are many, many, many synthetic cathinones, some that have yet been discovered and others that are yet to be discovered. And people are still looking for new synthetic cathinones that they can put out on the market that'll be harder to detect. So what would you do for adverse effects here? So for tachycardia, the beta blockers and the non-dihydropyridine calcium channel blockers. For palpitations and arrhythmias, starting out with those same two types of therapies can be good initially, although remember that things like electrical cardioversion would be needed in people with hemodynamically unstable arrhythmias or people who experience cardiac arrest. For hypertension, the same beta blockers and non-dihydropyridine calcium channel blockers. Just like with the other therapies for agitation, for aggression, for paranoia, for delusions, benzodiazepines. For seizures, benzodiazepines. Hyperthermia is something that you see with this product. And remember, if the hypothermia gets to be too high, you could end up with rhabdomyolysis. So cooling measures, trying to use dantrolene to try to cool the body as well in more severe forms. Rhabdomyolysis can occur from hyperthermia or because of overexertion for the people that are abusing these products. So just like things that you would see with cocaine and amphetamine abuse. Fluid loading to try to prevent acute renal failure after the liberation of iron from the myoglobin. And then finally, tooth damage and tooth loss from having a chronically dry mouth and from teeth grinding. Having a mouth guard could decrease the risk of teeth grinding when people are going through those issues. So here's the conclusion of this final section of today's talk. Synthetic cathinones don't show up on standard drug screening tests. The cycling of analogs in the products makes it difficult for commercial drug screeners to invest in trying to create rapid tests that include those analogs. Several synthetic cathinones are explicitly illegal to sell or possess, and their analogs are likely not legal, but it's harder to enforce. Synthetic cathinones can be contaminated and adulterated with other synthetic drugs, increasing their overall risk profile. Cardiac adverse events, psychiatric adverse events, muscle adverse events like rhabdomyolysis and tooth-related adverse events can occur, and the treatment of these adverse events are going to be similar to what you would use if somebody was overdosing on cocaine. So with that, I'll stop today's talk and we'll see if there's any questions. I'll turn it back over to you guys.
So
Thank you, Dr. White.
did I read the questions or do you want me to?
Either way, let me see if I go into Q&A.
And then also go into chat. So.
Yeah. So I have two questions here. One was, unfortunately, unless patients report tianeptine use, most EDs and hospitals will not identify the presence of this substance. My hospital doesn't even have an NPS to send out test available. Yeah, this is a problem, right? And it's a problem that occurs with a lot of these substances of abuse that don't show up on the screening tests is, that there may or may not be a patient or a family member that's going to be forthcoming and to tell people what these things look like, right? So toxicologists at that point will have to go through different toxidromes to try to identify some of the different components of the adverse effects and then try to treat those adverse effects accordingly, right? But it makes it a lot harder if you don't have that initial identification. And one of the issues that occurs is that the number of adverse events that we know about are probably grossly understated exactly for this reason. So I really appreciate you bringing that up. And, you know, and why adverse effects seem to explode at a certain time point once the knowledge of that product ends up hitting a critical mass, and then people start sending things out for full analysis, and then they realize that there's a lot of issues. But very, very seldom do they go back in time because they had, you know, frozen blood or taken hair samples or took nail samples in order to go backwards in time and to see whether some of those other cases were related or not. I had a patient who developed tianeptine use disorder and eventually required buprenorphine and naltrexone to treat. So the idea of using it seems counterintuitive to me. And yes, I mean, I think that that is, I think that that's true. There is a possibility that it could be because, you know, remember that, you know, buprenorphine is an opioid by itself, you know, so, you know, standard therapies like methadone also can have people abuse those products as well. The idea is to try to substitute one of the products for another product, but usually they're trying to substitute a product that has a much longer half-life so that it has less of that peak effect, that peak euphoria, and it allows people to have better throughout the day overall functioning. If you looked at the pharmacokinetics of tianeptine, it's really hard for me to believe it's going to be a good therapy for opioid use disorder because it has a quick onset of action and a relatively short half-life, right? Those things seem counterintuitive from that perspective. Were there any other questions that anyone had?
I had one question.
Yes.
So are there any numbers on how many polysubstance overdose deaths that test positive for tianeptine in the toxicology? And then is there any data specifically on tianeptine in combination with other licit or illicit substances causing kind of harmful synergistic effects minus what you would think of, you know, in high doses, the respiratory depression combined with something else that may cause respiratory depression?
Yeah, so other than the information that I presented, I wasn't able to find anything else with greater specificity. Usually with these things, what happens is, you know, they have some of these initial reports and they're a lot more aggregated. And then over the course of time, as more reports end up coming in and people have a little bit more time because it's in their consciousness, they end up getting teased out to a much greater extent. So I think, you know, looking at something like kratom as an example, right, where the same kind of thing, when people started to become aware of kratom and some of its potential adverse effects, the information was aggregated and it was really hard to be able to tease out. But then people will go back and, you know, spend more time to provide more information, which I imagine will be you know, probably coming up, you know, in the next couple of years.
I think that's all the questions I see.
Oh, great. Thank you.
A lot of information.
Thank you. Yeah, thank you, Dr. White. This has been fantastic, a ton of information. And I think everybody has enjoyed this as much as I have. Once again, we want to thank you for presenting today. Thank you to Kathy Keogh. This has been an excellent education for our NASCSA membership. On behalf of the National Association of State Controlled Substances Authorities, I would like to thank everyone who joined us for today's webinar. Thank you to our sponsors again for making today's webinar possible. And then we wish you a wonderful rest of your day.
Thank you.
Bye, everyone.